Well, good morning. My name's Trish Greenhalgh. I'm sorry I can't be with you in person, but I'm hoping to be there at the end by Skype to take questions. And I've been asked to speak on why doctors resist newly introduced technologies. I want to begin with a quote from a paper by Rodriguez and Posibon in 2005, and they observe something that I think most of you know instinctively. Most healthcare information communication technology implementations fail because despite high investments in terms of both time and financial resources, physicians simply do not use them. And it's that problem of doctors and other health professionals not using technologies that I want to address today. The classical view of resistance is that it is just stubbornness among health professionals. And there's a paper by Lorenzi and Riley which really articulates this view. And I should stress that I don't agree with this view, but it's very, very common in the literature. They say that challenges to system success are often more behavioral than technical. People who have low psychological ownership in a system and who vigorously resist its implementation can bring a technically best system to its knees. However, they say, effective leadership can sharply reduce the behavioral resistance to change. And I want to demonstrate in the rest of this talk that actually this depiction of resistance as behavioral stubbornness is very flawed. I think it's wrong. In 1983, Lynn Marcus wrote a very important paper which was published in a management journal, and she depicted resistance as due to three types of factor. The first was what she called people determined, people's personalities, their goals, their capabilities, and so stubbornness would perhaps be part of that. But she also said that resistance might be system determined, the features of the technology and how it is implemented. And most importantly, Lynn Marcus said, is the interactional or socio-technical aspects of resistance, the interaction between people and technologies. So, having introduced these three different dimensions of resistance, she then said there are three theoretical approaches to overcoming resistance. The first is people determined, such things as education, behavioral incentives, and what she called user participation involving people. The second is system determined, better technical design and the research into human factors. How can we design technologies so they're easier for humans to use? The third dimension is socio-technical or interactional. That is paying attention to the organizational issues and the relationship between users and designers. Now, socio-technical systems theory developed at the Tavistock Institute in London, which was linked to the British Psychological Society. And Simon, in a 1996 paper, said something very important. Work processes can be described in two ways: the way things are supposed to work and the way they actually do work. Software that is designed to support standard procedures can be too brittle. It's simply not adaptable, not flexible enough. Now, socio-technical theory introduced the concept of articulation. And by articulation, what the academics meant is carrying through a course of action despite local contingencies, unanticipated glitches, incommensurable opinions and beliefs, or inadequate knowledge of local circumstances. It's what we might call workarounds, making it happen even though it is a little bit clunky. A very important approach to computing, and I'm sure many of you know this, computer-supported cooperative work, which is now an interdisciplinary field of its own, is focused on the co-design of technologies and work practices. So Pratt et al. In 2004 distinguished one extreme of this co-design process where developers carefully design the application to fit the existing specific work practices of its users. And the alternative extreme is to completely reshape the work processes of the organization around the new technology, the new application. But actually, they said, most applications that are introduced in organizations fall into a middle ground, a mixture of supporting some existing work practices and attempting to change others. Now, here's an important slide. Apparent resistance by clinicians and by anyone else is often due to the subtle contingencies of work and not to stubbornness. And the CSCW, Computer-Supported Cooperative Work literature, doesn't talk about building information systems. It talks about growing information systems. And by growing, it's an organic metaphor. What they mean is to achieve a synergy between the technical system, the primary work task, which is usually clinical care, and any secondary work tasks such as audit, research, billing, other things that you might use the computer system for. Let me move on to a different set of theories of resistance, and I won't spend a lot of time on this. It may be something that interests some of you, and certainly I've done a lot of research on it, but I think we do need one slide on this. The notion introduced by Foucault of the panopticon of managerial surveillance. Once we have a computer system that is networked, we know that somebody else in another room, in another building, perhaps even in another country, can be watching what you and I are doing clinically. And we don't like that. As Doolin said in 2004, the representational, inscriptional, and computational techniques associated with information and computer technologies render individuals calculable and thus knowable and governable. Sometimes resistance is about resisting surveillance by the management. Now let me introduce network theories of resistance. And I don't have time in this lecture to go into detail about actor network theory, but at a relatively superficial level, it's quite a simple concept that technologies and people exist in networks, and there are close interdependencies between the institutional arrangements, the people, the technologies, and the work practices. These networks are dynamic and unstable. And I love this quote from Constantinides and Barrett, where they say that as these networks develop and change over time, the use of a technology may be transformed into non-use, resources that were initially gained may be later lost, and collaboration with key stakeholders may turn into conflict. And any of you who have tried to introduce a new IT system into a hospital or other healthcare environment will probably have been through this kind of experience. You think you've got it all set up, and then suddenly it doesn't, it's all falling apart again. Bruno Latour, who was one of the early architects of actor network theory, liked to talk about IT programs. And what he meant by a program was not just the technology, but aligning people and technologies in a more or less stable network. And he used the word translation, by which he meant, let's get people on board, let's get them to buy into the idea, start to use the technologies. And he said that resistance in this concept, you had to take a sort of networked view of resistance. People who are resisting the technology are mobilizing others to enact and stabilize what Latour called an anti-program, in which the technology is used differently or for different purposes. And Latour said that resistance must be studied in terms of the program, anti-program dynamic. And you can see this is quite an old reference. He was talking about this many years ago, but I think his work is still very relevant to healthcare technologies today. Now, when my colleagues and I looked at Latour's work with actor network theory, we very much liked the idea of a network that contained both humans and technologies. We liked the focus on changing dynamics and the idea that work is needed to keep the system stable. But we didn't like the under-theorization of the human component and the limited attention that Latour was giving, and then the actor network theorists were giving, to what I've called professional and moral issues. Because for me, as a practicing doctor, I have a very strong sense of professional purpose, and I want to behave as a good doctor should. And I think, Latour's work was developed outside healthcare mostly, and this wasn't such a big issue for him. So what I wanted to do was adapt actor network theory to take greater account of the moral aspects of professional practice. And I worked with a colleague, a sociologist called Rob Stones, and I'm just going to talk you through this diagram, where what I've got here is a timeline going from the top left of the picture, which is a long time ago, down to the bottom right, which is the present day. And I've got three different things which are evolving over time. The first thing is people. We all change over time. The second is technologies, which of course develop over time. And also what Rob Stones would call social structures, but I've called wider influences, the cultural, economic, legal, political, policy, whatever. You can put those all into those red boxes and say that all that changes over time as well. And those of you who have a sociological background will see that what we've done here is we've taken the blue and the red, the agents and structure, if you like, of sociology, and we've added this technological dimension. And so what we get here is a network of sorts, but a network which is historically evolving over time. And at any point in time, we can take a slice through this very complex network and focus in on some specific incidents and say, now what configuration of people, technologies and wider influences is producing what action, and what are the outcomes of this action? So really we're blending structuration theory with actor network theory here, but giving more of a focus on the human dimension. Let me talk you through how we can use this to analyze both the use of technologies and the non-use of technologies, in other words, the resistance that clinicians might show. So if we take a particular incident, say a consultation or an opportunity to use a technology, the first thing that we might do is look at what is going on in the clinician's mind, but also where did that clinician come from? What is this clinician's background, his or her identity, their values, education, skills, information literacy, and so on. How does that clinician view the context? What does he or she view as good professional practice? What is his or her clinical assessment of the patient and the priorities for managing them? And what does that clinician think that the patient thinks? And what do they think the technology can do? And then we ask similar questions about the patient, their background, identity, values, and so on. In what way is the patient sick, and how does that affect their interest and their capacity? What does the patient desire? And what does the patient think the clinician thinks, and what does the patient assume about the technologies? We could then ask questions about the technology. What was it designed to do? By whom and for what? What is inscribed in that technology? Somebody has built some assumptions into that technology as codes or options or decision models. And with what other people and technologies does that technology connect? And then a material question. What are the material properties of the technology and how do they play out? And then we ask, what action happens? What is done and what is not done? What actions are resisted? And can we explain that resistance with this detailed analysis of the clinician, the patient, the technology, and where they've all come from? And then we can look at the short-term impacts and the longer-term impacts. And Rob Stones and I wrote about this theoretical approach here in social science and medicine in a paper called Theorizing Big IT Programs. This paper at the time was not specifically about resistance, but that sets out the background to our theoretical approach. We then went on to add a moral dimension to resistance, and we began with this extraordinary book by Ziggy Bauman called Modernity and the Holocaust. And it's quite a troubling book. It is about the Holocaust and how it could possibly have happened in a relatively modern era. How come so many previously good people were kind of taken up into this ghastly happening? And Bauman, who is a Jewish academic who lost a lot of his relatives in the Holocaust and has said that we have a moral responsibility to learn from this dreadful event, said that the Holocaust illustrated the tendency of all bureaucracies to lose sight of the original goal and concentrate on the means. Let's develop a technical process for counting and processing. And he said that bureaucracy's double feat is the moralization of technology coupled with the denial of the moral significance of non-technical issues. And so he argues very powerfully in the book that what became a moral behavior was simply doing what the bureaucracy expected you to do, rather than asking this fundamental question, is this right or reasonable? Now, you can agree or disagree with that, but I would encourage you to read the book before you do either. So we took that. We moved on to something which I suppose draws on the same kind of approaches, but which is a bit more up to date and perhaps less controversial. Andrew Sayer, a sociologist who's recently published a book called Why Things Matter to People. And he distinguished between rationality, which is doing the thing right, in other words, following the protocol, obeying what the technology tells you to do, and reasonableness, doing the right thing. And he distinguishes this modern problem of efficiency of means versus the moral value of ends. So Sayer is saying that a characteristic of the modern world, of modernity, is the triumph of rationality over reason, the belief that new technology necessarily represents progress. And he talks about expert systems, the idea that you have a technology which contains a set of bureaucratic rules and classificatory systems which are delivered through the ICT. For example, many computer programs will have an embedded guideline or protocol, and these are in tension sometimes with what might be called the doctor's moral duty. What's best for this patient in these circumstances? So the moral dimension of resistance goes a bit beyond behaviorism. It includes organic design, which the socio-technical theorists have been talking about for 30 or 40 years, and it also includes the pressure to rise above, go beyond the expert system to reconnect with good professional practice. Let me give you a very quick example. My colleagues and I analysed a national IT system called Choose and Book in the UK. And this was an expert system in which it was designed to book outpatient appointments. So it was to be used by the general practitioner to book an appointment for the patient with the orthopaedic department or the gynecology department at the hospital. And the idea of Choose and Book was that patients would get hold of enough information about the different hospitals, and they would choose the one that was the best performing hospital. And so, for example, if the gynecology department in hospital A was very good, all the patients would want to go there, and then the hospital B, which didn't have a very good gynecological department, would go out of business. And so it was very much a market-driven policy and a market-driven technology. You probably can't see this very well, but this was what it looked like. It was designed to be used in real time during consultations, or alternatively, the patient could be given a password and they could book their own appointment later after they'd thought very carefully about the different information about the different hospitals. So let me go through this. In general, the clinicians were highly trained, they were very professionally motivated, they knew their patients intimately. This was British general practice, and the doctors had often known their patients for 10, 20 years. They also knew the local hospital very well, and they were often on first name terms with all the different consultants, and they were able to write a letter to a particular consultant. And they were motivated to use their personal qualities, their professional status, to provide care and comfort and to help the patient navigate the system. The patient, of course, was sick, perhaps anxious, trusted the GP, and really, in 99% of circumstances, just wanted to go to the local hospital to a doctor that the GP recommended. They really weren't very interested in looking up information about a hospital 50 miles away. The technology was not grown in a socio-technical way. It was materially very awkward. It fitted very poorly with work routines and interactions. It often crashed. And of course, it was inscribed with this neoliberal policy of choice designed to ensure that local practitioners obeyed this national policy. It reduced the referral process to what one of our GPs called the crudest kind of choice. And it imposed this role of rational chooser on the sick patient, which they didn't want to do. So what happened was Choose and Book was not used. Some practices used some very complicated workarounds, others actively resisted and protested. So Choose and Book was abandoned, but is about to be replaced by a very similar system. In summary, the GPs were resisting four things. The first was this policy of choice, which they didn't like, which was been built into the technology. The second was the socio-material constraints. It was really not a very useful technology. It's very clunky. The third was this interference with the contextual judgments by the expert system. And the fourth was altered social relations. Doctors felt that they were having to sell this government policy to patients. So how could things have gone better? These are my initial thoughts, but perhaps this is just asking us to move the deck chairs on the Titanic. If they had taken account of these things, firstly, a much less behaviourist approach to implementation, more co-design and co-development, as the socio-technical theorists would have, to move beyond this very crude, utilitarian, rational choice model of decision-making in medical care, to acknowledge that clinical practice is actually very nuanced, very complex, and what I've called exception-filled. Most patients don't fit the textbook. And finally, to acknowledge the complex clinical, social, and professional role of the physician. So, thank you for your attention.